Good evening, everyone, and thank you for giving me this opportunity. And to begin with, I'll start with saying that every human has a divine right to look human. So my topic is on the focusing on what are the recent advances in maxillofacial prosthodontics. So in many cases where the patient is having acquired or developmental defects with the faces, especially on the faces, the patients will end up with a lot of depressions and their social well-being, personal and professional well-being and activities are hampered. So though there are many advances in surgical field, sometimes all the surgical field may not give a satisfactory result. So there comes a role of maxillofacial prosthodontics where we rehabilitate with the artificial prosthesis. So what do you mean by this? Anaplastology is nothing but, in Greek, it is nothing but again or something made of, and it is a branch of medicine dealing with prosthetic rehabilitation of absent or malformed critical location of the face or body. And the term was given by Walter G. Spawn, and the member who does this is called as anaplastologist, who restoratively give the prosthesis in many parts of the body like face, feet, hand, and other soft tissue areas. It is a multidisciplinary approach where it includes the various team of the surgeons, speech therapist, radiologist, ENT specialist, psychiatrist, and we as a prosthodontist also come into play. The main objectives of this anaplastology is to restore the aesthetic or cosmetic appearance of the patient, restoration of the function, protection of tissue, providing the healing effect, and psychological therapy. Where are it can be used in the areas where the plastic surgery is contraindicated, like due to the advanced age of the patient or poor health, or if there is a large deformity, or post radiation tissue, if there is a poor blood supply. There, the plastic surgery is not possible. There, we can go and give an artificial maxillofacial prosthetics. Let me share a few of my cases done. And this is a patient, 50-year-old patient, who had a habit of smoking past 20 years, has got a swelling on the right cheek. And on all the investigations, we came to the conclusion of squamous cell carcinoma. And then we made an preoperative impression on the diagnostic cast was made, and the bite registration was taken. And as we discussed with the surgeon, they gave the demarcation design where they're going to resect the maxilla. So we fabricated obturator for this with the retentive clasp given, and wax template was fabricated, and the bite was articulated, and the sectioning of the cast was done according to the whatever the planned maxillectomy procedure. And we plan for this patient, since the processes will be bulky, we plan to have a hollow bulb. So we try to make a hollow bulb with using this reverse flasking procedure. So 3-pore system was done, and after flasking, the waxing procedure was fabricated where the wax portion was removed, and we adapted a wax template done, and the stoppers, this is the stoppers we can appreciate. So these stoppers were provided for the tissue stops, and the acrylic made added was added to the area to fabricate a hollow shim, and the flask was closed. And this diagrammatic, this is the, can you see the cursor, sir? This is the shim fabricated, which makes the hollow, the processes will be hollow inside. So say this is the shim, which is we made acrylic shim with the stoppers, and then the final processes was acrylized. And this is how the final obturator looks like, wherein it looks very bulky but it is hollow inside. And this is the patients during the surgical procedure. We inserted the surgical obturator, and this is the post-operative picture of the patient. And after the 3 months, the follow-up was regularly done, and then the definitive obturator was given, which was also a hollow obturator. Similarly, another case. This is a patient, female patient reported to our department with a cleft palate, including the entire soft palate and hard palate. and this intraoperative procedures. And these are the images pre-operatively we took. Uh,
Your slides are not moving. Can you put the PPT in the presentation mode?
we made a diagnostic impression with alginate, and the surgical plate was fabricated. And this is a
Sorry to
surgical
interrupt you, Dr.
template.
Padmaja. Can you hear me?
Yes, sir.
Can you put your
Yes, sir.
PPT in the presentation mode because your slides are not moving? At the bottom of the PPT, are you able to see that last symbol just beside 72%? Yeah,
Yes, sir.
click.
It's on.
Yeah, yeah, click on that. Yeah, perfect. Now we are at 32 slide. Is that correct?
Yes, sir.
Yeah, go ahead.
And after the surgery, the surgical template was provided. And this is, we can appreciate the post-operative follow-up. This is a surgical correction, and then immediately surgical plate was inserted. And then this is the post surgical follow-up, and we can see that the cleft was united, but posteriorly there was a still the defect was there, which couldn't be surgically corrected. So we planned a velopharyngeal prosthesis, wherein the patient was intraorally. We used a scanner to scan it. So is it visible?
The 34 slide is not yet loaded. We are able to see the slide 32 and 33.
Hello.
Yes, Padmaja, can you hear us?
Yes, sir. Yes, sir.
Yeah,
Is it visible?
yeah, we are able to see. So you are referring to the slide number 34, right?
Slide 34, sir.
Yes, we can see that.
So then we scanned it, and we fabricated crowns for this remaining teeth, and we scanned it, and we gave a fixed prosthesis. And this is the final prosthesis, which helped the patient to improve the phonation. So the speech was also gradually improved. There's one more case where this patient had accident, and there was a mandibular fracture. After surgical procedure, we proceeded with primary impression. Patient chief complaint was patient had a deviated movement. That means the mandible was not properly seated. So we plan to give a guided appliance. For that, we made a diagnostic impression. This is the diagnostic cast of the patient. We transfer the face-bow relation of the patient to an articulator. We did a final impression with border molding and final impression. Then we gave the twin occlusion. The twin occlusion concept is that it guides the mandible to a correct position. So after this trying in the patient's mouth, we finally gave the acrylized one, so that the patient was guided to go into the proper maximum intercuspation position. So like that, we do lot of intraoral prosthesis. very few on the extraoral, and we use various maxillofacial prosthetic materials like vulcanite, celluloid, acrylic resin, vinyls, latex, silicone elastomer. Recently, we are using this silicone elastomer, which is a room temperature silicone, which is MDX 4421, which has got a surface structure and hardness similar to that of the human skin. So, what are the various challenges we face? Is mainly we come across with the ocular prosthesis, wherein we conventionally we utilize the anatomy where if there are any undercuts or concavities, that can be used as a retentive factor for the patient to retain the ocular prosthesis. If not, we can use the mechanical retention by means of eyeglasses or headbands, straps, or sometimes magnets. If not, adhesives can be used or craniofacial implants are utilized. But in some rare cases, as you can see in this green, this is the ideal position of an implant for an implant retained ocular prosthesis if we are supposed to give. But there was one reference wherein a patient didn't had the anchorage option only here due to the fronto-orbital facial defect. We can appreciate in the CBCT also. This patient, so we couldn't place, in this case, the implant was not planned, so they went for a epiplatal system. Epiplating system is like utilizing the, it is a bone anchored prosthesis which utilizes the superiorly, it was fixed from the glabellar to the malar bone, and taking this as a retentive factor, the ocular prosthesis was given, and glasses were given to camouflage the margins of the prosthesis. This is one of the case report which we had done in our department where the patient had a missing eye on the right side. So we made an alginate impression, and this alginate impression was secured with the plaster and the gauze. Then the primary impression was graded, boxed, and we went for the mastercast fabrication and a custom. To inject the final impression material, we used a custom tray and a syringe. Then after making this inner eye shell was roughened, and the wax pattern was outly they were modified, and we added a outer shell with the wax pattern so that it will not hamper the patient's eye. And then a sticky wax are attached to the center of the iris, and we injected in the patient's eye and we recorded the final impression, and this is how the final impression we recorded. And then we selected the prefabricated eye close to the whatever is matching with the patient's the other eye, and we did a certain adjustment so that it will be perfectly sitting in the patient's eye. And we tried in the patient and asked the patient to do all the lateral movements so that there is no interference of it, and then we proceed with the acrylization with clear heat cure acrylic resin. And this is the pre-operative and post-operative images where we can appreciate the ocular processes which is closely matching to the patient's natural eye. So similar kind we had done in another patient where similar situation where the patient had lost his left eye. So we also proceeded, the procedure was almost same. The only thing in this is we used the digital iris attached here. We took the printout of this, the patient's exact right side thing. We got the color print then, and then we kept that as on the artificial eye acrylic resin, and then we closed it and did a characterization to match with the patient's natural eye. And the trial then was done in the patient's mouth, and just to give a slight glossy appearance we used a tint of glycerin on it and acrylized it, and this is the patient's before and after the treatment where you can really appreciate that it is closely matching with the patient's natural eye. Now, during all these procedures, there will be a lot of discomfort to the patient, what conventionally we follow. So recently we have these digital image capturing system like 3D MD face TM system, which just we have to sit the patient in front of it and it can capture the patient's defect. And once that is done, we can using this spectrometer kit, we can select the shade of that color of the patient, and this gauge will measure the color and gives whatever the colors available through the its library, And it also gives how much color, how much weight of the color should be used, so that we can mix the silicone material which can closely match with the patient's natural skin. Once that is done, we can 3D print. After the scanning, we can 3D print the color model, either clear or color model, and then we do a wax pattern using either wax or a clay sculpture. Once we check in the patient's mouth, then we proceed with the processing, and this is the patient with the final prosthesis. So these kind of processes will not only help the patient to get back their self confidence. This is coming to the ocular prosthesis. Now the toughest challenge is fabricating a nasal prosthesis. Patient who had a rhinectomy, they usually have these cleft palate type of formations when they speech. So the, and also during the cosmetic nasal processes, the drawback is that whenever they sneeze or cough, the process will drop off. So recently we have this allobone structure, subdermal processes type of designing. We can do it not only giving a cosmetic approach, it also allow the it redirect the airflow in a normal pattern, so that the patient's speech is also balanced and there is normal airflow also given. So this process is not only gives a cosmetic good appearance aesthetically, but also performs the function of rewriting the airflow. Sometimes this processes will take a long time, so we can digitally fabricate the provisionals. For the temporary nasal processes, we can also fabricate using this CAD/CAM technology, wherein patient face will be scanned, and once we get a scan, we can print the patient's 3D model, and with the references, digital reference, we can closely match the patient's nose, which matches to the patient's model, and eyeglasses also can be matched. And to retain the glasses and the provisional nasal processes, we can use this substructure, which will unite the prosthesis and also eyeglasses. So this is how the prosthesis will look like, nasal prosthesis, which is connected to the eyeglass. And this can be when the patient can easily wear it, and this will be a provisional nasal prosthesis the patient can wear till he get a definitive prosthesis. Next challenge we usually come across is we usually get hemimandibulectomy cases, but this is a reference I got it from Japanese Journal of Clinical Oncology, where a total mandibulectomy defect was rehabilitated, wherein the alginate impression was recorded, and then wax pattern was tried in the patient mouth to give a more retention, and clear rod was connected to it, which will go around the patient's ear as a retentive factor. And then once it is fabricated, uh, clear rod, and lingually there is a resin plate with the two ball clasps are given, which will engage the patient's upper front teeth, and that will act in the anteriorly as a retentive factor. So in this case, the ear acts as a one retentive factor, and these clasps act as a anteriorly as a another retentive factor. And you can appreciate the pre and post the patient's appearance before and after. Another challenge is treating the scars management, especially in case of facial burns. In that facial burns, usually conventional approach is like we make an impression on the patient's face. Already, the patient will have a lot of pain. Again, the physical contact with the impression material may irritate the patient more. So recently, we have this three-dimensional motion track laser scanner, which scans the patient's face, and we can print the patient's model. On the model, we can fabricate our mask, and that mask can be fitted to the patient. What is the advantage of this burn mask is it apply direct pressure over the wound site, so it will help in preventing the excess of scar formation, and also it protects the wound from unwanted shear forces, provides as a barrier from potential irritants, and also it, since it is clear, we can visually inspect the wound site. This is one of the reference where an acid attack victim, after using the custom burn mask, there was a gradual improvement in her facial appearance. Next is the cranial bone implants. They also plays a very crucial role in rehabilitating patient. This is one of the case where the patient had a fronto large frontal bone defect. So patient underwent, you can appreciate there is a puckered forehead skin, and patient surgically went, and there was they fabricated, they applied this free LD flap from the patient's own, and then they utilized it for covering it, contouring it. But after surgery, there was again, you can appreciate there was a sagging of his flap at the forehead. So the patient again went through cranial bone implant placement, which is a metacranial hemisphere. This can hold the shape of the frontal bone. It was designed according to the patient's frontal anatomy, and it was 3D printed. And this was used to give the stable contour, and over that the muzzle was draped. And here you can appreciate there is a stable contour of the patient. There is no sagging of the flap. So this is before the patient, and after the surgical treatment, there was a sagging of, and then after the prosthetic maxillofacial prosthetic treatment, there was a stable contour of the patient's frontal bone. Similarly, we have other issues where the patient would have lost his fingers, and also we can rehabilitate by giving the finger prosthesis, utilizing their remaining stump, and through the suction effect, we can place the finger prosthesis. So one of the case we had done where the patient had missing the terminal end of the nail. So we made an impression, and after scoring the master cast, we fabricated the wax pattern and tried in the patient's finger, and then we proceeded with the lab procedure and fabricated the finger prosthesis. And a little opacity was found, but it was a close match to the patient's remaining finger. So other ways also we can utilize either using the rings can be used for as a retentive aid. But recently we have this digital implant where it not only enhances the retention of the processor but also gives some amount of flexibility, so that the patient can perform the smaller actions like grasping the glasses, or some similar smaller activities the patient can do with this kind of prosthesis. And recent advances are that we have a high definition silicon which will give a lifelike prosthesis, which has got superior comfort, better cosmetic looks, and also gives a passive functional movement where the patient can perform the function. They can grab a glass of water, or they can use the laptop, or they can use the minute daily activities. Similarly, we can give it for partial foot prosthesis also. And recently we have published one chapter on the same topic, on the topic like latest innovations advancement in the field of maxillofacial prosthodontics, and this is a chapter, and I have published this as a review article also on the same topic. And one of the reference article I also found that the when the survey was taken on the quality of life and psychological evaluation of the patient after anaplastology, and around 76 patients were surveyed, and they found that their facial epistasis, they improved not only the mental well-being but also improved the quality of life among these patients who had a facial defect. So finally, I would like to conclude by saying that by Aristotle's statement that for things we have to learn before we can do them, we learn by doing them. So the more the cases, every cases is a new chapter where it requires a multidisciplinary approach, and with the proper treatment planning, we can give a better prosthesis to the patient, bringing them their self confidence back, and also improving their social, personal, and professional life. Being happily, they can enjoy their life. Thank you.
We are wonderful.
Hello.
Hello, Dr. Padmita. Can you hear me?
Yes, sir.
Yep. On behalf of the organizing committee, we appreciate your presentation, Dr. Padmita. It was really insightful. And we have few questions from the audience. First question is, how do you envision the future of anaplastology evolving over the next decade?
sir, your voice is breaking. Your voice is breaking.
Okay, can you hear me now? Hello, can you
Yes,
hear
sir.
me now? Okay. So my question is, how do you envision the future
Yes,
of
sir. Yes, sir.
anaplastology evolving over the next few years?
So now we are trying to remove all this conventional technique, and we are more into the digital aspect, wherein easily with the less chest time and less appointments, we can give the patient a good prosthesis, wherein instantly we can match their colors, we can take their impression, and earlier it was taking lengthy procedure, but we can shortcut these appointments and give a better appliances or prosthesis, which will give closely matching to their natural skin.
Perfect, wonderful. And one more question is, what role do digital scanning play in the modern anaplastology?
Yes, sir. The digital scanning helps us in not only like as I said, there's less patient discomfort because we are not troubling the patient. Again, there are chances of repeating impression and impression in conventional technique, which can hurt the patient, and also so digitally we can scan it, and there's less discomfort to the patient, and we can maintain that, we can document also for a long term, and also we can digitally we can show chairside only the how the end results going to look in the patient, like how is the treatment and how is the prosthesis going to improve their visibility or improve their looks. We can give it digitally only, so after patient also can see how the process is going to look like, which is not possible with the conventional one. So there's no try, nothing in the model, in the digitally on the screen they can see their how they're going to look after treating the treatment.
Perfect. And one last question, are there any recent innovations that have significantly improved patient comfort and quality of life?
Yes, sir. There are so many improvements are there. Now, again, there is more focusing on this tissue engineering, where the patient's own, one of the article I have gone through, where the patient's tumorous cells are converted into regenerative cells, where the patient's artificial, taking the patient's own tissue, we can regrow the teeth, we can regrow the fibers, we can regrow the ear or processes. Now the tissue engineering is improving, so maybe as we go on, we can regenerate the missing organs, so that there won't be any necessary of artificial, and taking the patient's stem cells only we can regrow it.
Perfect. Thank you so much, Dr. Padmaja, for
Hello?
your wonderful presentation. Indeed, it was very insightful for all the audience, and we wish you best research going forward. Thank you so much for your time.
Thank you so much, sir. Thank you for giving this opportunity.